Hello, I am very excited about the opportunity to present at this Twist of Fate conference. My name is Dr. Shane Morris, and I am an associate professor of pediatrics at Texas Children's Hospital and Baylor College of Medicine in Houston, Texas. I currently serve as the director of the cardiovascular genetics program, as well as director of the fetal cardiology program here at Texas Children's. I also serve as associate director of our pediatric cardiology fellowship. And I came to talk a little bit today about our experience at Texas Children's Hospital. And I also have one of our trainees who's going to detail the experience. So I wanted to give a little bit of background about our cardiovascular genetics program and our connection with arterial tortuosity syndrome. So as part of our cardiology program, we run a large cardiovascular genetics program, and this is considered a subspecialty within cardiology. Our major areas of focus in our cardiovascular genetics program are genetically mediated aortic and arterial disease. So that's the group which sees patients with arterial tortuosity syndrome. We also have a group that specializes in heritable arrhythmia. So these are rhythm problems that are genetically mediated. Congenital malformation syndromes, these are genetic syndromes that cause heart disease and might cause birth defects in other systems. Congenital heart disease, this is when we see familial heart disease. So families that have heart disease, and we're trying to figure out the genetic reasons. And also a condition called cardiomyopathy. And this is when there's a problem with the muscle of the heart. They're not necessarily structural abnormalities, but genetics that cause the heart to fail sooner. Some other areas we do see that involve genetics and the heart are lipid or cholesterol disorders, muscular dystrophy, and tuberous sclerosis, but those are mostly followed in multidisciplinary clinics outside our cardiovascular genetics program. So this is our team of patients, of providers that see specifically our aortopathy and arteriopathy patients. So you can see across the top are our two MDs, as well as our physician assistant and our nurse practitioner, as well as our two fabulous genetic counselors and our administrative support group. So conditions that we see in our arterial tortuosity or our arteriopathy clinic are, of course, arterial tortuosity syndrome, as well as Marfan syndrome, Loeys-Dietz syndrome, vascular Ehlers-Danlos syndrome, Turner syndrome, familial aortic aneurysm and dissection disorders, cutis laxa type B, also called fibulin 4, Myhre syndrome, and anytime a child has aortic or arterial dilation or tortuosity of unclear etiology, we see them as well in our group. So I wanted to give a little bit of background how I got involved with Twist of Fate and arterial tortuosity syndrome and this meeting, which I am so thrilled to be part of. Shortly after I became faculty in Baylor in 2010, one of my young patients was diagnosed with arterial tortuosity syndrome. And I learned of two older patients that were cared for as our hospital as well. And I just found this condition fascinating. It was so rare, and the fact that we had 3 patients was so interesting. Andrea Taylor reached out to me about this and said, please connect them with the Twist of Fate. And I was so thrilled to find that there was an advocacy group and a place of support for these families. And I was very fortunate to attend the national conference that she hosted in 2017. So I'm going to go through what our baseline assessment is, which is here. And then one of our trainees, Dr. Bita Salamat, is going to present one of our recent research projects regarding our patients. We have a small number of patients, it's 6, but as anyone who's watching this knows, this is ultra rare. So hopefully this provides some insights into how the course of things can change over time. So what we do if we see a new patient with arterial tortuosity syndrome is we first have them come to our cardiovascular genetics clinic visit, which always is staffed by a provider and a cardiac genetic counselor. We do a really detailed physical examination. Now, most cardiologists really focus on the heart, but in our clinic, we focus on the heart and every other part of the body to see if we can get some insight into the genetic manifestations. We do, at diagnosis, do head to pelvis imaging of the vessels. So that is either an MRA or a CTA, plus an echocardiogram to look at valve function and to look for any birth defects or congenital heart anomalies. If other patients in the family or other members of the family have not been tested, We will do what we call cascade screening. So we will see if other people are affected. We can test parents to look if they're heterozygous carriers. We can look at siblings to see if they're affected. We want to make sure everyone who's interested in testing gets testing done. We will make orthopedic referrals if we have any concerns about skeletal development, including scoliosis. We universally will make an ophthalmology referral given the manifestations that I'm sure you're aware of with the eyes and ATS. And we will give other referrals as needed. So we can refer to pulmonary or surgery, GI, urology, whomever we think is specialized. And we're lucky because we have such a large aortopathy and arteriopathy program that our referral providers really understand aortic and arterial disease. I know that ATS is quite rare, but it does have overlap with a lot of other conditions like Loeys-Dietz syndrome and some with Marfan syndrome. So our referring providers can really help because they are also experts in those conditions. And if we see significant aortic dilation or aortic aneurysm, we do talk about medical treatment for this with antihypertensives. This is kind of controversial because thankfully there has not been dissections described in arterial tortuosity syndrome, but there is always a question because aortic aneurysms are quite common, whether this could occur. So if we have someone with a very large area of dilation or aneurysm, we will consider medical treatment. So a current update, and again, Dr. Salamat is going to go over it in more detail. We have 6 patients to date that we follow. Unfortunately, 1 has passed away and 1 has moved out of the country, so we actively follow 4. And as I said, Dr. Salamat, who is a pediatric resident at Baylor College of Medicine, is going to present our recent project, and I'm excited for you to hear some of our results. And Dr. Salamat, if you want to come on the screen, and I will hide mine.
Hi, thank you, Dr. Morris, and thank you to everyone who made this possible. And so our project today is called the arterial tortuosity syndrome, and we're looking at the longitudinal assessment of cardiovascular features. So I have no financial disclosures to report, though I will be discussing off-label uses of ACE inhibitors, ARBs, and beta blockers for ATS management. The purpose of this study is to review and assess the longitudinal course of cardiovascular features in those with ATS, which to our knowledge has not been studied or published before. And so a little bit of introduction, as many of you know, ATS is distinguished by loss of function, homozygous or compound heterozygous mutations in the SLC2A10 gene. And the cardiovascular features that are typically seen include tortuous and elongated arteries, aortic stenosis, abnormal implantation of aortic branches, pulmonary artery branch stenosis, and arterial dilations. And like Dr. Morris had mentioned, to date, there have been no known arterial dissections published in the literature with those with confirmed ATS. So for our methods, this project was conducted as a retrospective cohort study. The inclusion criteria included those with confirmed homozygous or compound heterozygous mutations in the SLC-A10 gene and phenotypes that were consistent with ATS as in our patients seen at Texas Children's Hospital from the year 2000 to 2021. Cardiovascular imaging, medications, and interventions were reviewed, and Z-scores were utilized as an analytic factor to determine what standard deviations our measurements were from the average values. We calculated Z-scores with weight and height and cardiac dimensions by using the Pediatric Heart Network calculator, and Z-scores greater than or equal to +2 were considered dilated. And then finally, our slopes were calculated using mixed linear regression. So 6 patients aged 3 to 19 years old met the inclusion criteria for this project. We did have an additional 2 patients who were referred from Qatar to our institution, though they were never fully evaluated at Texas Children's Hospital. 5 of our 6 patients are male, and the age of diagnosis ranged from 3 weeks to 16 years. Ethnically, we do have 2 of Asian descent and 4 of white Hispanic descent. And our patients' countries of origin included Mexico, Nicaragua, El Salvador, Jordan, and Korea. The patient from El Salvador is suspected to be from El Salvador, but otherwise those are the different regions where we've noticed our patients are from. And all of our patients were diagnosed with either whole exome sequencing or aortopathy panels. So this slide here shows the different variants in our patients and their associated protein changes. 5 of our 6 patients had mutations in exon 2, while 1 had a variant in intron 3. And while 2 of our variants were classified as variants of uncertain significance, we do believe that they are pathogenic given the homozygosity of the mutations and their associated physical features that were consistent with ATS. And amino acid changes here in 23, 105, and 246 were also seen in the study published by Byans in 2018, though the exact amino acid changes noted here are different than those that were published. So overall, all 6 of our patients were found to have aortic tortuosity, tortuosity of other arteries, and aortic root dilation, which, as I mentioned before, is a z-score greater than or equal to +2. And notably, none of our patients had arterial dissections. I just want to make a quick note that the total shown here represents the number of features with specific features compared to those that we had documentation for. So there are some patients that that documentation was not available for us. And so from this graph, or I'm sorry, from this table, we do see that 5 of our 6 patients had other cardiovascular defects, which included PFOs, open PDAs, VSDs, duplicated renal arteries, and so forth. 4 of our 5 patients had dilated valve annuli, and with 1 unknown due to no documentation. And 4 of 6 of our patients had stenosis of the pulmonary arteries. Other features that were noted to be involved included the musculoskeletal and craniofacial features, where 100% or all 6 of our patients had features consistent with ATS for both. And we did have 83% or 5 out of 6 of our patients with cutaneous manifestations as well. And these are the other features that we have seen in our patient population. So this image here is a CT angiogram of the posterior view of the thoracic and abdominal aorta. And from this image, we do see that the aortic root and the ascending aorta are severely dilated. And there's also significant tortuosity of the rest of the aorta, head, neck, and abdominal and pelvic arteries as well. This slide shows our results for the aortic root dimensions. So I'll start from the top. This graph here is showing the aortic root size in millimeters on the y-axis over time on the x-axis. This x-axis is representing how old our patients are and their change in aortic root dimension over time. And from our calculations, we can see that on average, from all of our patients on average, we had an increase in aortic root size by 1.1 millimeters per year. The second graph here is showing the aortic root z-score change over time in the same 6 patients. Again, the x-axis is representing the patient's ages in years over time, but the y-axis this time is showing the z-score. The gray area here is highlighting the normal range of z-score. And on average, although the aortic root size increased by 1.1 millimeters per year, the aortic root z-score only increased by 0.04 per year. The second slide is showing ascending aorta changes. And so the x-axis here is showing the age in years. And on the top graph, the y-axis is showing the change in dimension or the increase in size in millimeters. And from our calculations, once again, we saw that on average from all of our patients, that the ascending aorta increased in size by 1.1 millimeters per year. This bottom graph is showing the z-score change. So again, on the x-axis, we have time in years. And on the y-axis this time, we have the z-score. This gray area here is showing the normal range of the z-score. And from our calculations, on average for all of these patients, the ascending aorta increased in size by 0.15 z-score per year. We are also in the process of analyzing dimensions and z-scores over time for the sinotubular junction, aortic valve annulus, transverse aorta, main pulmonary artery, and the branch pulmonary arteries. So in regards to pharmaceutical therapies, 3 of our patients were on beta blockers at a given point in their lives, of whom 1 was also on losartan. 1 of our patients underwent right and left pulmonary artery balloon and stent angioplasties due to branch pulmonary artery hypoplasia and stenosis. And another of our patients was advised to undergo an aortic root replacement and branch pulmonary artery placation because of compression of the bilateral bronchi. So overall, all our results do show progression of the cardiovascular features in those with ATS, but it also shows clinical variability between patients. And although the aortic root and ascending aorta increased in size on average, this was not unexpected as children grow, and we expect the aorta to grow as they do. But importantly, they did so with minimal changes in their z-scores. And the findings here also show that aortic root progression in ATS is similar to other aortopathies like Marfan and Loeys-Dietz syndrome. And so this is a randomized controlled trial by Hoskabal published in Pediatric Cardiology in 2018, showing the results of aortic root dilation progression in those with Marfan syndrome. This is showing the z-score over time, which is similar to the findings that we had. Another study presented at the American College of Cardiology by one of our former colleagues depicts the aortic root z-score in those with Loeys-Dietz syndrome, which was also similar to our findings. Importantly, none of our patients had arterial dissections. However, patients with ATS are at increased risk of arterial dissection because of their increased aortic root dimensions. And so it is recommended that these patients be treated with medications. However, there are no current official published guidelines highlighting treatment options for those with ATS, as the role of TGF-beta in ATS is ambiguous. But nonetheless, in case-dependent scenarios, beta blockers, ARBs, and ACE inhibitors may be used to help alleviate aortic wall stress, as done in those with Marfan syndrome. And additionally, cardiovascular surgery guidelines are similar to those with Marfan syndrome, which indicates surgical repair of the aortic root or ascending aorta when dimensions exceed 50 millimeters. And while our study demonstrates relatively stable z-scores, it is important to do serial imaging. The current recommendations state that echocardiograms should be completed every 3 months until the child is 5 years old, and after 5 years old may be case dependent. However, it is strongly encouraged that echocardiograms be done at minimum once a year to not only monitor the progression of the aortic root, but also to monitor the associated arterial tortuosity and arterial stenosis that may occur. And finally, each child should have a baseline MR or CT angiogram with 3D reconstructioning of the head, neck, chest, abdomen, and pelvis in every 3 years after that. We did have some limitations to our study, with the largest being the small sample size that we have, given the rarity of ATS. We also did use a retrospective design, which prohibited us from standardizing imaging and measurement techniques, follow-up imaging and pharmaceutical therapies, and we did have loss of follow-up for patients. And it's always important to consider individual provider biases as well. However, in conclusion, our study has discovered potential new variants. It has shown from our findings, we did have a predominance of ATS in South and Central American descent, of those with South and Central American descent. And it did demonstrate that although the aortic root and ascending aorta increase in size, their Z-scores remain relatively stable like other aortopathies. Future areas of study include assessing the role of medications and surgical approach in those with ATS, and also utilizing vertebral artery tortuosity index to help predict adverse cardiovascular outcomes and risk for early cardiovascular surgery. And so I just wanted to say a huge thank you to Andrea Taylor for the opportunity to present this work and for bringing us all together to learn more about ATS. And I'd also like to thank Sarah Stevens, Taylor Beecroft, Dr. Wigan, and Ben Jacob for their added support and help. And lastly, for Dr. Morris for not only allowing me to take on this project, but for being an amazing mentor. And if you'd like your child to be enrolled in our study, please don't hesitate to email me at beta.salamat@bcm.edu. And additionally, if you have any questions, please feel free to reach out.
Thank you so much, Dr. Salamat. And please do reach out to us. We're happy. We would love to meet anyone. We would love to enroll anyone in our study. We are enrolling anyone up to 30 as the primary person. But if there's people over 30 in your family affected, as long as a child's affected, we would love to enroll them too. I was just going to make a couple comments about the medication question because it comes up a lot. There have been a lot of patients who have undergone aortic surgery because of the thought that there's a risk of dissection, and there might be a risk of dissection. We just don't think it's that high. So it's definitely controversial in the community. I generally will do meds in the presence of moderate to severe aortic dilation, but we're always trying to learn more. And if we find that that's not effective, we might change our minds. I don't know. And that's why we would love your help in learning with us. And if you have ideas, for most of our focus is on cardiovascular research, but if you have areas of study you think would be interesting, please feel free to reach out to us. We look forward to hearing the rest of this conference that Andrea has put together, and we look forward to meeting you in a live meeting in the future. Thank you so much.
Welcome to the lecture about anesthesia for ATS. I think you'll find this topic interesting, as there are special considerations for ATS for anesthesiologists. I'll not be discussing off-label drug usage, and I have no financial interest to disclose. I'll briefly mention the genetic causes of ATS, outline the tissue defects associated with ATS, and then discuss the anesthetic implications. As many of you already know, ATS occurs due to a gene defect causing a deficiency of the GLUT10 protein. As a result, some parts of tissues grow too much, as GLUT10 protein normally acts to restrict growth of some tissues to prevent overgrowth. Lack of growth restriction results in defective tissues that cause disease. Some of these defects are important considerations for anesthesiologists. In particular, GLUT10 protein puts the brakes on the development of blood vessels, bone, and soft tissues, including muscles. Without GLUT10, overgrowth of arteries, deformations of bones and joints, poor muscle tone, weak airway walls, and hernias of various kinds can result. In preparing for anesthesia, a complete review of the medical record is necessary to identify all organ system dysfunctions of ATS. Sometimes we need to check with other specialists for details. It helps to see the patient in advance and particularly speak with the family so that we can prepare for special equipment or medications for that particular patient. Each anesthetic for an ATS patient is a designer anesthetic based on the condition of that patient at that time for that anesthetic. Since ATS is a progressive disease, different preparations may be in order than were needed for a previous anesthetic. We review everything with special attention to organ systems affected by ATS. Being anesthesiologists, given that we often breathe for our patients, we have a particular interest in the airway. Our upper airway evaluation includes a history of snoring or apnea spells while asleep, difficulties with previous anesthetics, particularly in placing a breathing tube. We also pay close attention to some of the things that are associated with ATS, such as a short jaw, also known as micrognathia, and a high arched palate. Both of these things make the space within the mouth very small. In addition, the mouth opening could be small by itself. It's important for us to know if the patient can sublux their jaw, that is, jut their jaw outward. We also look in the mouth at the uvula and the soft palate. We check the distance from the throat to the chin, called the hyomental distance, and we have a particular interest in head and neck mobility. When we look in the mouth, we use a classification system called the Mallampati classification. Mallampati really is telling us how much of the back of the throat we can see when the patient opens their mouth and says, "ah." If we can see the uvula, or even part of the uvula, it's associated with either a class 1 or a class 2. We know that patients that have class 1 or class 2 views often have a more direct route from the mouth to the vocal cords and the airway for placing a breathing tube. Those patients where you cannot see the uvula, or even, maybe not even the back of the throat, we know that those patients are associated sometimes with difficulty in placing a breathing tube because we can't see from the mouth to the vocal cords using a laryngoscope. The high arched palate is depicted here. Generally, it appears that the top of the palate is much higher above the teeth than, say, a person who does not have one. This is associated with ATS. This is a close-up view. You can see sort of a deep recess, but it's not so much that the palate is high. If you notice that the teeth on the sides are closer together and that the upper part of the mouth is much more narrow, and it gives the appearance that the palate is high. But what we're really interested in as anesthesiologists is how wide the palate is, because a narrow palate gives us very little room to use when we're putting in a laryngoscope and ultimately a breathing tube. So if things are very narrow, we have less space. This is a depiction of a laryngoscope and a view inside an unconscious person's mouth. And those two little things that you see in the middle are the vocal cords. And the person, the anesthesiologist, is holding a laryngoscope, which is really nothing more than a fancy tongue blade made of metal with a light on the end. A high arched palate makes that person's mouth much more narrow. In fact, it may be so narrow that it only accommodates the laryngoscope. And attempting to put a breathing tube in may be complicated because there just might not be enough space for both a laryngoscope and the breathing tube. In an unconscious patient, especially one that's unconscious and facing upwards, the muscle tone becomes so slack that the jaw and the tongue fall backwards, and they close off the air passage from the nose down through the back of the throat and through the windpipe, and the patient can't breathe. You can also see the mouth is often occluded as well. This is a condition that sometimes is referred to as swallowing one's tongue, which is a complete misnomer. No tongue gets swallowed in this picture. It's just that the muscle tone is so slack that the airway occludes, and this patient is unconscious, so they make no maneuvers to recover. This arrow depicts the point of occlusion of the airway in the posterior pharynx or back of the throat. By lifting the jaw and bringing it upwards, one actually brings the entire tongue forward as well, opening this space and creating an air passage that can be used with a mask, for example, to push air into the trachea from the nose and mouth. Subluxation refers to moving the jaw joint. The TMJ, or temporomandibular joint of the jaw, is unique in that it works as a hinge, but it also can unhinge. For example, when someone takes a big yawn, the jaw comes out of its groove and slips forward, and that allows you to jut your jaw forward if you're asked to do so, but it also allows us to do so with an unconscious patient. So this is a depiction of someone's jaw, and you can see it has a hinge point there, which is used for just opening and closing. But to open your mouth really wide, that whole joint slips forward over the edge of the socket where the joint fits, and that's subluxation. Some people with joint disease are unable to do this, so they cannot open their mouth very wide. And in addition, if they're unconscious and we need to open their airway, we cannot use the jaw lift technique to bring the tongue forward. This is another skeletal depiction of where the edge of that jaw is as it comes out of the socket and comes forward. And you can see that the lower teeth are now well in front of the upper teeth. In order to look in someone's mouth and be able to see the vocal cords and the trachea beyond, we talk about 3 different axes. 2 of them are nearly in line already. So if you were looking from the back of the throat, you could almost see down the windpipe. But if you're looking in the mouth, you'd just be looking at the back of the throat. there is a positioning that allows alignment of these visual axes. And when that occurs, when you have that alignment, it means that you can look in the mouth and maybe see the vocal cords. And of course, when you see the vocal cords, the trachea or windpipe is right below that. By just positioning a person with the head extended and the neck flexed in the so-called sniffing position, we can get close to aligning these three axes so that we could look in the mouth and see the vocal cords. Typically, just doing this does not allow that view. A laryngoscope, as I mentioned, is sort of a tongue blade with a light on it and a handle. These are two examples of a curved type and a straight type. These are used to compress the tongue sort of into the jaw so that we can get that last little bit of tongue out of the way in order to look in the mouth while the patient is in the sniffing position and see the vocal cords. And if we can see the vocal cords, we can put a breathing tube directly through them, and we put it in with that little balloon thing down, the cuff, and then once it's through, we inflate that soft little cuff to help make a good seal so that we can breathe for an unconscious person, such as one going to have anesthesia. This is a depiction of the laryngoscope in action from the side view. And you can see that it's used to compress the tongue into this space below the jaw, which allows us to look between the upper teeth and the laryngoscope straight down toward the airway and the vocal cords, which would be right here, and this is the windpipe. So it's a straight view through here. The tongue is attached roughly between the ends of the jaw at the widest point. And it's attached to something called the hyoid bone. So if you lift the jaw forward, it brings the tongue with it. So someone who has a small jaw has less space in this area. And this space is important because the tongue needs to be compressed into this space with a laryngoscope so that we can see. By looking in the mouth, we can compress the tongue out of the way and we can see the vocal cords and place the breathing tube. So back to this picture. This is the laryngoscope compressing the tongue forward, and hence we can see and we can put the breathing tube directly in that direction. And it really doesn't look like what I just showed you, nor this really. Here's the vocal cords. If you look through the vocal cords, you can see the rings of the trachea or windpipe. This is the epiglottis, that little flap that is a trapdoor closure so you can swallow food without getting something on your vocal cords or in your windpipe. And this is what it looks like in real life. That upside down white V are the vocal cords. Trachea is below, and this is the epiglottis. So sometimes, even after lining everything up and using your laryngoscope, you may only see part of the vocal cords. This is a great view here. We call that a grade 1 view. And if we can only see the back half, it's a grade 2 view. We're pretty satisfied with either of those because we can usually get the endotracheal tube in fairly easily. Sometimes, though, all you see is the epiglottis. And if the epiglottis is really short, you can't really pick it up with a laryngoscope. So you can't really see the cords, but you know they're under there somewhere. And at other times, the view is so bad that all you see really is the base of the tongue and the back of the throat. And all this good stuff that you see in A is covered up and around the corner. We have a classification system called the Cormack-Lehane classification. And when we put a breathing tube in, we always make a notation in the patient's medical record of what the view was. So now I got a Mallampati grade for looking at the mouth, but we also have the Cormack-Lehane view which is what we see after we actually get down to business and put the laryngoscope in. That's something that carries forward in the patient's medical record. Now, if we can't see anything with the laryngoscope, we have special fiber optic gizmos that we can use to see around the corner. This is a fiber optic bronchoscope. One looks through this end and you can see out this end, and there's a light that illuminates the path. And I'm depicting on the right side, putting a laryngoscope down that has an endotracheal tube on top of it. And if you go down and follow it along and find the vocal cords and go through, you can slip the endotracheal tube down over the bronchoscope into the trachea, and then take out the bronchoscope, and the breathing tube is left in place, in this instance through the nose and through the windpipe. So, important technique for finding one's way. Disadvantages are if there are a lot of secretions or if something's bloody in there, it may obscure the view and you can't see where you're going because the end of the fiber optics may be covered up with something opaque. There are other scopes too that use fiber optics. This is a laryngoscope that just has a more of a curve than we use for the ones that require direct vision. So instead of looking down here, we're actually looking at a screen, and it's using fiber optics to get the view right here. And we can go down and get this view, see what we need to see, and then we put a breathing tube in next to this scope, and we manipulate the breathing tube through the vocal cords by just watching this view, sort of blindly with one hand positioning it. We will see the endotracheal tube come in and we'll position it through the vocal cords. And once we're through, then we take everything out and leave the breathing tube in place. So in an oral endotracheal tube, looks like this, goes through the mouth, and then sort of around the corner of the tongue, and then through the vocal cords into the trachea, and that little soft balloon then helps provide a nice seal for breathing. We also evaluate the lower airway, and of course we look at what happened last time with anesthesia in the breathing process. We also note the patient's usual respiratory rate, and we also like to look for tracheobronchomalacia. That's a big long word. It basically means somebody who has some weakness of the trachea or bronchial walls, the big airways that go to the lung. Sometimes that causes air trapping and difficulty with breathing, especially in an unconscious person. We like to know if that particular person has, when they're just doing their daily activities, shortness of breath, or if they've had recent lung function tests. We examine them, we listen for end expiratory wheezing, which could indicate airway collapse. We look at the shape of their chest, which sometimes gives us an idea of whether they have air trapping due to collapsing airways, or if they have scoliosis, another problem that ATS patients have. A curvature of the spine that sometimes restricts how well the lungs can expand. So this is a view down the trachea, and the trachea is kept open by these rings that are sort of shaped like a big C. On the backside, generally, there is not a ring. So, but the cartilage, each of these cartilage rings forms enough of a shape there that keeps the airway nice and open. You can see there's a whole series of those rings as it goes down to where it splits into the bronchi. If those rings are insufficient and they don't quite make a C, in fact they are just not even making quite halfway, then this back part of the trachea bulges into the trachea, and it makes the inside much less round with much less space. And as the patient breathes out, the pressures in the chest are sufficient to push this wall of the trachea in and then restrict the air from leaving the lungs. So when the patient goes to take a breath in, this will open a little and let some air in, but since the old air was still there, they can't take as big a breath, and so they have air trapping. This is a depiction of how that would go. In a normal patient, there's a little bit of an indentation there where those rings don't come together. But in a person with tracheomalacia, where the cartilage is not quite enough of a circle, then they can have some pretty severe narrowing during exhalation. Inhalation, everything in the chest tends to expand. Exhalation, it all collapses. And unfortunately, it doesn't let the air out when it does that. Another depiction yet besides this one in the bronchus, where there is collapse on exhalation, it would result in air trapping in this case, in the left lung as the patient breathes out. The right lung in this depiction is unaffected. And this is a depiction of scoliosis. You can see how the spine is deformed. It shifts the ribs. It brings the diaphragm, the breathing muscle up. It makes the space available to the lungs very small. So the lungs cannot fully expand, and as a result, they usually don't grow enough either. And the patient has a restriction and they can't take very deep breaths. And if you combine that with not being able to take a deep breath, but then also not being able to exhale fully with tracheo or tracheobronchomalacia, there can be severe limitations with breathing, either awake or unconscious, but especially unconscious. This is another severe photograph, and you can see that the rib function, which normally these ribs will rise and fall with a breath in and a breath out, likely does not occur or occur sufficiently in this patient to be able to expand their chest to take a breath in. We also look at the heart and arteries. We look at the previous heart findings, echocardiogram if there has been one, their exercise tolerance, and we're interested in their usual blood pressure, heart rate, and whether they have hypertension or not. Hypertension might be indicative of severe kinks and curls in arteries that are distal to where we're taking a blood pressure. So if the smaller arteries are kinked and not allowing flow, sometimes we'll measure higher pressure in a blood pressure cuff, say at the upper arm, because the flow just cannot be adequate enough without having high pressure. We look for the pulses, we look for veins for intravenous access when we place an IV. We listen for heart sounds and murmurs, which are indicative of perhaps congenital heart disease. We listen for the second heart sound, because if it's really loud, then it could indicate that there's some high blood pressure to the lungs that might need to be addressed. And we consider getting repeat EKGs or chest x-rays. This is a normal heart with a normal blood flow. And most of the time these great vessels are intact in ATS patients. It's when they start branching out beyond the heart that the tortuosity due to overgrowth can occur. We look at the valves. The aortic valve is in the red oval, and the pulmonary valve is in the green oval. If there is high blood pressure, those valves slam shut with more force, and the second heart sound, which can be created by either valve, is louder. And so that's why the second heart sound is important. These are the vessels that go to the head from the aortic arch. and the patient on the left has ATS. And you can see that those arteries didn't really stop growing when they were of adequate length compared to the normal patient on the right. So they twist and curl and sometimes kink, and they can restrict flow to the head and the brain, and create a high blood pressure requirement in order to generate adequate flow to the head and the brain. The higher blood pressure would be in the big arteries before it gets to the curlicues that are created by the overgrown arteries. And these are added angiograms. And here's the patient with ATS. And you can see that their blood vessels or arteries to the head have overgrown and have become curled and kinked and take a meandering path. Sometimes this can limit blood flow to the head and to the brain, as compared to the normal patient, which is viewed on the right. These are the blood vessels that are at the base of the brain. A normal patient on the left has we call it the circle of Willis, an anatomist. And this is sort of a general staging area for blood as it goes to the brain on both sides. And in a patient with ATS on the right-hand side, you can see that there are more curves and twists and possibly kinks that exist there. And those get worse with time as those vessels continue to grow. This is why repeated examinations of neurological function and heart function and lung function are important over time, because these items do progress sometimes. And additional photographs of blood vessels that are going into the upper body in ATS patients, and lots of curvature. So ATS can also cause weakness in some other tissues that keep organs in place. Hernias can happen when bowel passes through an opening in the normally tough covering of the abdomen, and that hernia, or bowel usually, can escape into the soft tissue beneath the skin as it goes through this tough covering, the fascia. The trapped bowel, once it's out there and it's through this hole, can require emergency surgery because it starts to strangulate. The hiatal hernia is another kind of hernia that happens through the breathing muscle, the diaphragm, between the chest and abdomen. And sometimes there's just a little too much space in that area, and the stomach can actually start to migrate through this hole and become trapped in the chest. And that is a painful condition that sometimes can cause some esophagitis and upper abdominal pain. Often they have gastroesophageal reflux, because once this is up here, there's extra pressure, and acid that's produced in the stomach can then enter into the esophagus and cause a burning. The urinary system is also affected. Kidney problems, urinary problems. Sometimes it's really hard to get a Foley catheter in place during surgeries completely unrelated to kidneys and bladder. Obstructed kidneys can ultimately result in decreased kidney function or create conditions for kidney or bladder infections. The lining of the urethra is often wrinkled or less smooth, and particularly in males, it can be difficult to get that Foley catheter to track through the urethra to the bladder. Sometimes we have to call a urologist to place the catheter for, say, cardiac procedures or things that are going to last longer than 3 hours, say, prior to the start of surgery, but after we've begun anesthesia. And the urologists are certainly very experienced with passing difficult Foley catheters. Irregularities and dilations of the path of urine are sometimes present with ATS. So the connections between the kidney and the bladder, the ureters, can be abnormal. There can be irregular divots in the bladder. There can be false valves, such as posterior urethral valves, that prevent the bladder from completely emptying. These things can cause repeated bladder infections. There can be thickening of the bladder wall with these little out pouches. So lots of things there that can impair function or prevent complete emptying, setting up a condition for repeat urinary tract infections. Skeletal abnormalities are known as well. There can be joint limitations, inabilities to completely extend, or fixations in flexion. There can be arthritis. There can be dislocations or joints that easily dislocate. Some of our patients with ATS cannot really lie flat, and they need some bolstering with pillows or padding. We like to know what the patient's normal range of motion is, especially with the head and neck and the limbs, because while they're unconscious, we don't want them to be in a position where it's going to place a strain on a joint or tendon or muscle, so that when they awaken later or emerge from anesthesia, they don't have pain from malpositioning or being in a position while unconscious that creates a painful condition after they regain consciousness. And this is just an example of a child who cannot fully extend his arms. And knowing that degree of ability is important. Same for scoliosis. Sometimes we need to pad the patient's back so that all the pressure doesn't perhaps lie on, one side of the chest versus the other. By having a child bend forward, we can often get a better idea of the severity of rotational scoliosis, so that we know how better to pad that patient. Frequently, I like to have a patient lie down on the operating bed or the MRI table or whatever we're going to use, and then ask them, as we put pillows and padding in, when they are most comfortable. So sometimes they'll tell us, well, I need a little more under my low back or something like that. And I really use their feedback to get an idea of what adequate padding is like for them. We look at the skin closely too. Wound healing can sometimes be problematic. Sometimes it's really hard to put an IV. Sometimes they have a history of easy scarring, so we want to avoid anything that, maybe if we usually suture lines, we may opt not to if they have a lot of scarring from tissue access. We look for unhealed wounds and visible veins for IV access later. So for anesthesia, we have the airway considerations, upper and lower, special fiber optic equipment we may need for putting a breathing tube in for intubation, considerations for tracheal or bronchomalacia, namely air trapping. Sometimes we don't really need a breathing tube. We can use other airway devices, such as laryngeal mask or just a mask case, or maybe we can just do sedation and let the patient have a nasal cannula while they're asleep and doing their own breathing. Often less is better. With the heart, we need to know what the function is like, what their normal baseline function is like when they're running around at home. If there's any restriction to coronary artery flow, that's important because the coronary arteries can be involved as well. And if they've got some impairment of flow to the heart, they may have angina at baseline. We look for aneurysms, things that may burst if the pressure is too high. Perhaps we'd ask for better blood pressure control before they come to anesthesia. And we're also interested in that high blood pressure to the pulmonary arteries or pulmonary hypertension. There's attention to the urinary part, especially with placement of the Foley catheter and need for a urologist. And the padding for the skeletal anomalies and limitations for placement of their joints and head and neck for that matter when they're going to be unconscious for any procedure. And the intravenous access is important. I always like to have a 2D ultrasound machine available so that we can see veins that are not visible at the surface of the skin, particularly veins that may be straight enough and big enough to accommodate an IV catheter. Considerations for monitoring during anesthesia include maintaining the blood pressure close to what the value is when they're awake, running a 5-lead ECG during anesthesia just so we can be aware of any parts of the heart that may be not getting enough blood flow. Invasive arterial pressure monitoring can be difficult because sometimes the arteries are just not straight enough to put a catheter in. We can use the ultrasound machine to see if the arteries are straight or if there's a portion of them that may be adequate for placing an arterial line. There are newer non-invasive continuous blood pressure monitors that provide a beat-to-beat blood pressure, but they're generally only available for patients that weigh 40 kilos or 88 pounds or more. So the small kids and the babies don't really have another kind of equivalent monitor. We like to use continued tissue oxygenation monitoring, or NIRS, near-infrared spectroscopy. It tells us what tissue, how much oxygen is going to various tissues with patches that are placed on the skin. And then Foley catheters give us an idea of how the kidneys are being perfused by measuring urine output. So this is an example of non-invasive continuous blood pressure monitoring. And it basically is measuring pulsations in small arteries in the fingers and correlating that with central blood pressure. So designed for big people, nothing available yet for small people and infants. This is the near-infrared spectroscopy. Patch is on the head, shines two versions of infrared light through the head, catching, for example, part of the brain in this case, and giving us an idea what the saturation of oxygen is in the brain at that area. We often put a second one over a muscle, maybe the low back muscle, to get an idea of tissue saturation at the same time. And this is what the monitor looks like. It can read up to 4 different patches on various parts of the body. Typically we use 2, one on a forehead, which gives us the brain and the frontal part of the skull, and then another one somewhere else, perhaps on the low back. Nerve blocks can be really valuable for patients with ATS. They minimize the amount of narcotic pain medicine they're going to need. They breathe better. They're less sleepy. They have better air movement. I think they recover faster. We inject the local anesthetic numbing medicine around a nerve. And although there is a risk of injecting into a twisted artery that may be next to a nerve, we use an ultrasound machine so that we can see where we're going and where that anesthetic is going. Some blocks are around nerves that aren't next to big arteries, and of course those are awesome as well. Epidurals and spinal blocks are a little more difficult to avoid vessels because we really can't see very well through the bone where we're putting those particular catheters. This is an example of an ulnar nerve block, and here's the needle, and the ulnar nerve lives right there, and there's the artery. We can see it. It looks like a black circle, and we can go right next to the nerve, and then we can inject some local anesthetic, and that actually makes the nerve sort of appear because this numbing medicine is sort of floating around it. But it's much safer now that we have high-resolution, two-dimensional ultrasound now for regional blocks. And I think it really is a way to go for many patients, especially older patients who may need nothing more than a good block. So post-anesthetic care is a continuation of everything that we do. We like to continue using the same kind of monitoring that worked while they were anesthetized. We optimize their breathing and their airway patency, and we make sure that their pain is well controlled. We really like to focus on non-narcotic pain relief because it doesn't depress breathing. So non-steroidal anti-inflammatories such as ibuprofen, as well as acetaminophen, are often given prior to the end of the procedure. And if we're going to use a muscle relaxant, we like to use something that has a short duration of action and something that we can completely reverse when we're finished, so that there is no muscle weakness left over. And our handoff to other medical personnel who'll be caring for the patient after the anesthetic really needs to be thorough and complete, so that we educate them as well about the facets of ATS and what they should be aware of when we bring them a patient. It's a relatively newly recognized disease, so education is the best option, and we can help facilitate that as perioperative care specialist, the anesthesiologist. So in the future, we need more definition about the course of the disease as it progresses. It would be great to have a better idea of how often certain complications occur and what their prevalence is, what other organ systems may be involved, or how the severity or how the disease progresses with other organ systems. And I say other organ systems just because it includes everything besides the airway that we're interested in. The metabolism could be varied too, depending on the effects of the disease on the kidneys and the liver. And then, of course, advances in alternative monitoring and new machines and gizmos that help us with anesthesia. Ultimately, we need to publish and share information so that people are more aware of this disease, and especially for anesthesiologists. So in summary, each patient gets a designer anesthetic, and we do that by knowing their medical history, their previous anesthetics, their medical issues. We do a thorough examination, and we specifically plan for that patient by having special equipment as needed, special monitoring as needed, and then individualized positioning during the procedure, and post-operative care as a continuation of our intraoperative care. So a lot of things that are going on for anesthesia for ATS. Sometimes there's so much focus on the procedural studies or surgical interventions that the anesthesia part sort of, is something that's not immediately apparent until someone needs anesthesia. So hopefully this lecture helped enlighten you a bit. Thank you very much for this opportunity to present this.
Wow, now I have a lot to think about.
Well, while you're thinking about it, let's allow everyone else to hear some words of wisdom from Dr. Armel Pinton.
Hello, everybody. Thank you for giving me the opportunity to present the plan we have with Andrea and explain to you what is a patient-focused drug development and why we want to do it. So why do you think we want to go on drug developments? First, the treatment you receive are not adapted specifically or designed specifically for ATS. And there is an unmet medical need. So you would say the basic science of ATS is not fully understood, but that doesn't mean that you cannot start finding treatments. I work with other foundations that are polygenics, for example, and they don't even know exactly which genes are involved in their disease, but they are already starting screening for treatments. Why are they doing that? It's because they know exactly what is needed for their disease. they know how to measure it, and they know at which point they can say that a drug is effective or not. So this is exactly what we want to do for ATS, prepare you to go to drug development. So for the next few minutes, I'm going to show you a presentation, an extract of a presentation that explains you the basics of drug development.
The goal of most foundations are to cure or find treatments and improve patients' daily life. The purpose of this presentation is to help foundation understand the different steps and requirements necessary to transition to a drug development support. To be active and find a cure, foundations need to be involved in drug development. And at a certain stage in the process, will need the intervention of a pharmaceutical company. We will guide you on how to be prepared to convince private companies to invest in your disease. The first step is to understand the process to get to a treatment or a cure, how to develop and bring a drug to the market, who the stakeholders are, when to interact with the different stakeholders. The road to a drug on the market is often represented by a horizontal flowchart. Starting from investigation to characterize the disease, then molecules, also called chemical compounds, are tested for the disease, undergo modification for optimization and safety to become a potential drug. These different steps are called the preclinical development. When the optimized chemical compound fulfills the requirement to be tested in human, the clinical phases are performed before going to the market. Where are the different steps performed and by whom? Research is executed in scientific academic centers, mainly universities and NIH, and is focused on the biological characteristics of the disease, so performed by biologists. The first step, really concerning drug, is when you enter the preclinical studies. It is performed in either biotechs, pharmaceutical companies, CROs, or specialized governmental organizations such as NCATS, and sometimes in academic labs. For successful preclinical studies, you need to have pharmacologists or biologists specialized in pharmacology working together with medicinal chemists and admit toxicologists. The clinical phase are performed in hospitals by clinicians. The drug is brought to the market by a pharmaceutical company with the business development necessary. The process is regulated by legal, financial, and human aspects. The patient, through the foundations and patient advocacy groups, need to be very actively involved in the whole process. They are the support and beneficiaries and should be at the center of the process. The FDA should not be reduced as the judge at the end of the process. They are a tremendous support all along the drug development. They will help you address the right issues from the beginning, as I will explain in this presentation. And of course, the pharmaceutical and biotech companies are the major power in the drug development process and manufacturing. When to prepare? The process seems to be linear over time, and some make the error to take it that way, losing a lot of time and efficiency, which is not the best way to convince a company to invest in you. Prepare all the tools necessary for each step before you get to that step. For example, if nothing is ready to measure clinical outcomes, the FDA won't let you put your patient at risk by trying a new drug. And the pharmaceutical companies know it. You need to come to them with at least a partial completion of the requirements. This takes years. Instead of first testing molecules in model, and when an interesting molecule is found, starting to think about the next step and realize it will take years, start preparing the clinical stages before or at the same time as you start the academic science. The advice from the FDA are for starting points, the most important thing is to start with a consensus definition of the disease. This is fundamental before anything else. You can also establish diagnostic criteria and care guidelines. For that, organize clinicians' workshop. Take the occasion to contact and gather clinician specialists of your disease from different continents if you can. That will help increase the patient volume and stimulate the attention and the wish to help for your disease. The second point is define what your specific rare disease needs now. Most rare diseases have large and diverse phenotypes. Your patients are the expert in their disease. They will give the information for drug development and evaluation. The FDA advises to define the critical issues, the most important symptoms for the patients in their daily lives. It will facilitate the decision to approve a drug if it is proven that the target of the drug will be a benefit and change the patient's life. As an indication to what to look for, you can follow the guidelines from the FDA. I indicated the website page here. Mainly, identify the symptoms and impact of the disease on daily life, the current treatment options, the important disease subpopulation, or patient characteristics that should be represented, the phenotypic and severity variation, and if there is a need to focus on any particular subpopulation, such as children, for example. How to get all this information? The ideal would be to perform an externally led patient-focused drug development, PFDD, with the FDA help. An acceptable option is to gather as many patient, caregivers, clinicians as you can and follow the guidelines. Take into consideration that teenagers have a tendency to lower the intensity or importance of their symptoms. The patient-reported outcomes, what we call the PROs, have to be carefully evaluated.
So I hope that now you understand the context of drug developments. So to summarize, the key points is that if you want to test drugs on patients, you need the FDA approval. So you want to have all the points ready so that they give you the approval to start testing in clinic the new drug on patients. So for that, we need to target the right issues and measure the right benefits. So you will say, well, you have scientists, you have clinicians for that. No, we need you, because what the FDA thinks, and they're right, is that the endpoints are not necessarily what the key opinion leader or clinicians usually measure. It should be the points that matters for the patient. We need also to be clear on your perspective on the balance between the benefits and the risk that you are going to take or ready to take to get those benefits. So in fact, is the new drug going to improve your life or make it a nightmare? And we need to define also with the clinicians and with you what we are looking for. So at what endpoints, at what amount of action of the new drug do we decide that the drug is effective? So it doesn't go to the next. So the big plan over the next few years with Andrea and with Twist of Fate for the ATS patients are first to collect a comprehensive patient input. So as many data as we can for every one of you on the burden of the disease and the current therapy. Then we need to develop a holistic set of impacts that are the most important for you, for the patients. Then from that, we will identify and develop good measures for the impacts, for the set of impacts, and that will be used for the clinical trials to test the drugs on patients. We are going to incorporate the measure into endpoints. So determine really when we can say that a drug is effective or not. How are we going to do that? So we are going to send you some questionnaires and ask a lot of questions and try to gather everything. So the questions are going to be on demographic, history of diagnosis, the main medical issues, the impact on everyday's life, and the balance, as I said, between risk and benefits. We are going to ask two groups of people, the ATS patients or their representative, and the carriers of the gene mutation. So the legal aspects of the data we can gather, the experience data, who can collect that? The patients, the caregivers, the researchers, and the patients advocacy groups, so twist of fate. What are exactly defined as experience data? Well, that includes experience, perspectives, the needs and priorities of the patients related, for example, to this list, but we can also add other things like the symptoms of the condition and the natural history, the impact of the condition on your functioning and quality of life, the experience with treatments, that's very important, the input on which outcomes are important to you, the patient preference for outcomes and treatments, and the relative importance of any issue as defined by the patient. So the next step that we are going to do is that you are going to fill up a questionnaire, I hope. We are going to do it printed or online. Then we are going to have some virtual individual interviews to further down and deeper the questions. And then we are going to have a hybrid online and in-person patient forum where there will be an analysis of the questionnaires, patient panels, discussions and testimony on the impact of ATS on life and the risk and benefit balance. So I hope I convinced you, and I really would like you to join and participate to the patient focus forum. The forum will get on the drug development. Thank you for your attention.
I love her.
I think my head is overloaded.
Maybe I'll be a doctor. Stay tuned, we have a lot more information coming your way.
So what was it really like for you when you found out about Maggie?
Well, it was hard. See, because we were told for so long that something was wrong. And there was so much frustration just trying to get through the system and trying to sort of get to a diagnosis. And to be perfectly honest, I knew before we went to Mayo Clinics what the result was going to be. Because I saw it on the way they do their My Chart. I think they publicized the notes. So her neuromuscular doctor had essentially put in her notes saying, the whole exome is back, here's what it says, genetics needs to tell them.
I think the online systems are really good, but the same thing happened with me because when they did like Aiden's full body scan or whatever, of course I got it and I read it right away before the doctors had called me, and they were telling me that, you know, the arteries were so tortuous in his brain and that it looked like an aneurysm. And so like I even called Bert panicking that something was really wrong and I had no idea what to do.
Well, in a way though, for that particular news, it was a little bit better that I had it going in.
Yeah.
Because I was able to sort of process it mentally for about 2 weeks before we went and actually got the result. And then that was one of her cardiologist had already mentioned that disease as one of the differentials. Like he had mentioned it because he didn't have a full body scan, he just had a chest image, and that was one on the list. So it was not a complete surprise when that's what came up. So I had already been researching, so we're driving 4 hours. I'm researching this to get the result, to then already have gone to find you.
Yeah.
And then that's when we ended up talking was.
I mean, that's just crazy that you would email me the night that we're starting the first.
Well, there was so much pressure, like, okay, so now we know what's going on, who's the best treatment, you know, because I'm a nurse. To me, it's like, well, let's go where the numbers are. Let's go where I know that the best care can be based on outcomes, based on best practices. Yeah. So let's see what we can do. Well, I'm researching it and I can't find anything on it. So I think my original email to you was, hey, we're just diagnosed, where does everybody get their care? I hadn't realized though at that point. So it's one thing to get the news of the diagnosis, and I had already sort of come to terms with that because I had known for a couple of weeks. The part that I didn't realize was that there was nobody that really had a lot of experience with it. I mean, it was so ultra rare that there was nobody that could say, yeah, that they had a lot of experience with it.
So were you really scared, or just
I
more
was
concerned, or
more like confused, and I don't know, like scared is one word for it, but just thinking there's got to be some mistake, there's got to be some clinic that can manage this, there's got to be some best practice guidelines, there's got to be
That's
some
exactly what I thought.
Research. Really. I just have to look harder. I just need to look in a different place, and that actually takes a lot longer to do.
It takes a really long time.
The conference actually sort of helped with that, because then that sort of solidified that initial conference that we went to, like, oh, wait a minute now.
Yeah.
So let me get this straight. There's no best practice guidelines. There's no really clinical data. There's no research, and there's no community that can say they have more than one kid. I mean, that was really the problem.
Well, and that's really crazy because it was just 2 years ago, but now we have several communities with more than one kid. So,
right, in 2 years, it's unreal.
And that's what baffles me, is that there can be so many of them out there that we don't know about. What is it with these moms, why they're not talking and asking questions and reaching out and finding others like them? Why wouldn't they want to know that there's a community that can support them?
Well, that's what we want to obtain with the registry, that we get all the information centralized, and from that we can make a start on how patients should be followed and how they should be treated.
It's the best way we can contribute to research, really. And actually it'll ultimately make it easiest on me, because I'm inputting the data once. I'm not trying to walk around with these medical records going doctor to doctor, trying to contribute to the research.
The thing that I like about it is that there's only 2 people in the study that could even see any data that would tell like a name. But if other doctors wanted to research, then all they could see was the information that was given about the particular disease, and those people would be given like a medical record number, sort of. So
this will be a great boost for research, for clinical research, and data are safe and protected, so that's important.
I think it'll be a game changer. I think it'll be a really big deal.
But I think our core group of physicians, like we have, like I adore our doctors at Children's of Wisconsin, because they're my people, they're who we see, they're who manage me, and I have a great deal of love and respect for them. But when I come here, these are also my people. These are my doctors, these are my daughter's doctors, but it's so much like more family down here. You know, like, you're gonna watch my kids play in the pool so I can run and take care of something. I mean, it's really more of a family down here, between the families, but then also the doctors. I think that we are all sort of on a informal, very personal level. I mean, when we were at clinic yesterday, the clinic doors were open because we were all sort of just walking between each other's rooms, hanging out, you know, making the best of things.
Taking care of each other,
yeah,
really.
Clinic is just...
It is hard.
Clinic is miserable by itself. I mean, it takes you 2 hours to explain the disease to the doctor that's trying to see you, and then, so, you know, when we're in clinic together like that, it made it kind of fun, where we all were kind of bouncing back and forth.
Yeah,
One
it
person
really
was
did.
running for coffee. You know, the kids were sort of playing in between.
Well, the
So
thing
it was
that I like
awesome.
about it is that, I don't know, I just lost it.
I think social gathering is important. Knowing you have questions yourself, but knowing that other people have the same questions and that you can freely talk about it without explaining your whole story again, that's also a relief, and
Right.
that's important.
I know that it might be a little inconvenient to see all those doctors in one day, but the importance of that one day is immeasurable. The information that you gather and what
then
it could do to
put
help.
together.
But it also can sort of like solidify in your mind, like for Maggie, for my daughter, she, the cardiologist that I love here too, was able to basically read her echo the same way her doctor in Wisconsin. Well, to me, that means we're on the right track. We're doing something
Exactly.
good.
And that's what's so
You know?
important about having a second opinion. And, you know, even if you want to get care at your local hospital, getting that initial visit by the Center of Excellence makes a really big difference, because then that your doctor can go back and confer with the experts and find out what they might need to do differently.
And then also contributing to research is important.
It's like you've always got a second opinion just right there if you need it.
Well, you never know when you might learn just one new thing. For us specifically, the eye stuff is really big.
It is.
We come here. I mean, that is last year. That was like our really big thing, and it kind of continues to be.
Has been confirmed this year, so
right.
That's something to follow. That's something new we got out of the clinic.
You need your eyesight. It's no joke.
One, the amazing part about it is it all started because one kid had it, and then we started looking at everybody else, and then before you know it, now we've got all these findings, and these kids all need to see an ophthalmologist. So because of what we did, we will save kids' vision. And what's really amazing is the information that we're gathering with the registry. What's really amazing about gathering all the information with the registry, it's not just going to help ATS patients, it's going to help all diseases, really, what we can learn and help teach others.
Yeah, it's a great example of how care should be organized around rare diseases. So it's a wonderful initiative.
Great, excellent.
Can you say that one more time? It's really a great example of how care should be organized around rare diseases. That's important. That's huge.
Right.
Yeah.
But it's not just about research when we come, because we would come if it wasn't for research.
Oh,
we
yeah,
would come
definitely.
to see our family. I mean, this is our family reunion every year.
Exactly. I mean, to see our kids together and how they connect and...
Oh, it's unreal. And the acceptance
definitely.
of each other. I mean, it's awesome.
It's lovely too. It's kind of wonderful to see all these children playing around and see also how they move around, how they actually live, how they do stuff together. That's wonderful.
How much, when you're looking at our kids play, how much data are you collecting in your brain just from watching their interactions and playing?
Well,
do you separate? Like, are you looking at them like a clinician? Like, oh man, I see this, I see this.
No, I'm not looking at them as a clinician, but I think somewhere back in my brain there is some retention of data.
Yeah, right.
So they're looking like that, they're behaving like that, they're moving like that.
Because in clinic you probably can't, because like they don't always do what you want them to at clinic.
Yeah.
All the standing up, moving this, measuring
That's
this.
correct.
But when you're watching
when
them
they're
play,
playing, then you see
it's natural.
what problems, the laxity, the hyperlaxity of the joints.
Or watch it, they get
fatigued, the fatigue, the muscle hypoplasia. You can see that. And that's something you not always observe.
Well, how often do you have a physician come from the other part of the world?
I know.
And he sits and he swims with our kids and he blows bubbles and has fun and
talks with us, hugs us.
Yeah, he's one of us.
Absolutely. We're our family.
Thank you.
Love you guys.
So when I started the nonprofit, I started out as just a mom, trying to figure out what was best for Aiden. And then we started gathering families, and then we had the first international conference, and we invited you. And So I thought this is really cool that this doctor from Belgium is going to come over and talk with us. But I didn't realize like what you had done. I just thought that, I didn't understand the real meaning of what you had done. And then you weren't just some arrogant doctor who had done all this work, and you came as, when Aiden got sick, there really wasn't anybody that could do very much for him, and Arkansas Children's Hospital was so great with the care and the plans that they made. But then I knew that there really wasn't much else out there, and there wasn't very many other families. And then Aiden got really sick, and we had to go to a different hospital, and they wouldn't listen to me. And I think that's what bothered me the most, is because, I knew more about ATS, and I was more of an expert than the doctors were, and that was very scary. And even though I brought all of Aiden's medical records, and I sat down with the doctors and I explained to them and all the different procedures he had had and what kind of reaction he had had and all those things, they still just acted like he was another patient with pneumonia. And it wasn't like that at all. Like, Aiden was really sick, and if we had continued at that particular hospital, I am afraid that Aiden might have passed away, that we would have lost him. And it was because of that I said no more. And I said, we have to do something different. We have to have research. We have to have doctors involved. We have to do something for these kids, and we have to find others. And if I don't find any others, then Aiden could die. And decided it was time to start the nonprofit. And that was a very hard decision for me, because my degree wasn't in that field, and I had no idea how to run a nonprofit. And I spent about a month of sleepless nights, and I kept thinking, I'm not going to do this. Like, this is just too much. There's got to be some other way. But then I would wake up and I would cry, and I would think, if I didn't, and something happened to Aiden, I would never be able to live with myself. But if I did it, and something still happened, at least I would have known that I tried everything. And at first, I almost felt a little bit upset, because I felt like I was being really selfish for the reasons why I started the nonprofit. But in reality, I had no idea what I was even creating. And I don't think it's until I met you that I really understood. So I just want you to know that when I met you, it changed the dynamics of everything. That it went from just being a nonprofit and we were gathering patients to where we really had direction and that we were really going to go somewhere. And I don't think that if you weren't involved, that we would be as successful as what we are. That you really honestly care about the patients. You really care about the organization, and you put a lot of time and effort into it, and we're all very grateful.
So actually I feel the same. Since I engaged in the nonprofit, we got samples, we got clinical data, and we got a wonderful team, a wonderful family of patients. That's fantastic, and I would like to keep it that way. I think we can make a huge difference. Thank you so much for that.
Thank you for being my partner.
Thank you.
Wow, that was really good information.
I agree. It's really cool that these moms get to talk to the doctor outside of the hospital setting.
Yeah, I'm sure it's a lot easier to talk when you're not in an exam room.
Yeah, I think that's why we should have monthly Zoom calls. Maybe some of the doctors will even participate.
Yeah, and that way the patients could have discussions with other patients and occasionally the doctors.
Yeah, I mean, that's kind of the whole idea. If this is something you're interested in, make sure to visit our website or contact Andrea Taylor, and let's make that happen.
Now, the moment you've all been waiting for.
We'd like to present our brand new design. I love it. It's amazing.
And it's not only for ATS, it represents a lot of different rare diseases. Connective tissue disorders, autism, Down syndrome, if you know, you know. My favorite thing about the shirt is trying to find the codes.
I love the colors. If you'd like to order any merchandise, please visit the ATS website for more information.
Hi, everybody. My name is Matt Edick from the Michigan Public Health Institute Center for Strategic Health Partnerships. Today, I'm going to talk to you about new skills and innovative partnerships to compete for rare disease funding from the Patient-Centered Outcomes Research Institute, or PCORI. Before I get started, I just want to let you know that I have no conflicts of interest to disclose. And a few other disclosures there for you. I'll leave on the screen for a second. You're welcome to read them. And also just like to mention the funding for this work that I'll share for you. You see there's a fairly long list. Most of the work that I'll talk about was funded by multiple sources and kind of blended and braided funding. And so a lot of it is funded by PCORI, but also HRSA, Newborn Screening Translational Research Network, NIH, HRSA, etc. So you can see all those. And then I'll go ahead and dig in. So as I mentioned, I am from Michigan Public Health Institute, and I'm the director of the Center for Strategic Health Partnerships. And for any of you that are not familiar with MPHI, or Michigan Public Health Institute, or my center, we refer to it as CSHIP, and you'll probably hear me say that several times through the presentation today. CSHIP operates at this interface between researchers and public health professionals and patients and clinicians and payers and really any kind of stakeholder you can think of in the healthcare arena. And we come to that interface to help these stakeholders identify barriers in accessing care and then developing strategies to overcome them with the ultimate goal of improving health outcomes. So this is what we do in the Center for Strategic Health Partnerships, but interestingly enough, this is not where my career started out. And so I'd like to take just a minute and tell you a little bit of background about me and maybe share a story with you to lead you to the space where I started working with PCORI and why I really like working with PCORI and I'm so passionate about this work. So one thing I want to share with you, a little lesson learned over the years, is that everybody communicates in different ways, and everybody's story has things in it that you can learn from the facts that they tell you and the events that they share. But there are also other things that you can learn about people and maybe about communities and about culture, things that are never spoken, but you start to sort of hear and listen to and understand as you hear stories from individuals, especially stakeholders in your research projects. And so one thing you might notice is that my story here has no words in it, and that is for a very specific reason. It's because on a personal level, I don't like to read. And because I don't like to read, whenever I think about telling a story, I think about it in pictures. What does that story look like? How can I show you my story, say, instead of having you read my story, right? And so that's something, that you might learn about me. If you hear me speak enough times, you'll notice I tend to focus more on pictures and less on the words. So anyways, I want to lay out a story for you. I was in graduate school when this story begins here, and I was just getting started in my professional career. I was studying genetics. I was in an amazing lab. My mentor was publishing several times a year, and she had lots and lots of grant money, and I was with all of these really smart people around me, and they were great mentors. They were really teaching me all the things I needed to know to be a successful scientist. And so I was in this really great environment, and I was, I don't know, 2 years into graduate school, and my fiance at the time and I got married, and this was like, just sort of part of my long-term vision for my life. I had good education. I was getting married. We soon after started our family. We had our first child. I finished grad school. I had this wonderful job. Okay, I got to pause. Not really a wonderful job for any of you that are scientists. I was a postdoc, so wonderful work, but long hours and bad pay. But nonetheless, let's get back to the story. So I have this great job, and again, I find myself in a good lab, a very productive lab with a mentor who had good research funding and was publishing papers and was very willing to bring me along and teach me what I needed to know. And so if you think about my career trajectory at that point, it was on a nice upward trend, and it was going exactly where I always dreamed it was going to go. I was wrapping up my postdoc, looking for my first faculty position, thinking about my new lab and what it was going to look like and how I was going to hire people and all of these things. And so I was on my way to work one day, and I as a postdoc, another thing I didn't mention that maybe made my wonderful job a little less wonderful, so I had about an hour commute to get there. And so I was probably 3/4 of the way there, and I get a phone call. And so I answer the phone, and I see it's my wife. And it wasn't unusual to hear from her when I was heading into work, especially being such a long drive. But there was something different. I could hear something in her voice. Something wasn't quite right. And she hadn't said anything yet, but I started to get this really bad sinking pit in my stomach. And she said to me, "Where are you? Can you come home?" And I said, "Well, I'm almost to work. What's going on?" And so it turns out my wife at the time was about 15 or 16 months pregnant, and she had been having complications with her pregnancy. And so far, we had no idea what was going on. Physicians were paying attention and watching and doing tests and things, but didn't really know what was going on. So she had an appointment that morning, and her doctor said, "We need you to go see a perinatal specialist. Can you go right now?" And she said, "Well, can I go tomorrow?" And he said, "No, it would be better if you could go right now." And so she was on her way to the perinatal specialist. I was almost an hour away. And so I turned around, and I very promptly, without getting a speeding ticket, made my way back home and met up with her at her appointment. And it was a scary appointment for us. We heard a lot of things that we didn't really understand, and not because of the knowledge of it, but just from being overwhelmed. We were hearing things that we didn't think were possible or real, and that something was very wrong with our child that wasn't born yet, and that's what was causing the pregnancy complications. And there were a lot more questions than there were answers, but it was definitely a critical situation. You could tell by the tone of voice and by the urgency in everybody's action. And so my wife and I sat there in the room, both not really saying much of anything, but I think both thinking pretty close to the same thing. We're facing something that we have no idea how to climb over or through or around. And it turned out that was true. We were facing a really big thing at that point. And the only thing that we really knew at that point is it was going to forever change the course of our life, for our career, for our marriage, for our family. Everything was going to be different, a lot different than we ever imagined it to be. So fast forward about 6 months from that point, and my son is born. So this is my son, Elijah. He was born in December 2006. And Elijah was born with Down syndrome. And Down syndrome in and of itself is not typically a condition that is fatal, for example, or has any significant medical complications. There are certainly medical complications that are common in Down syndrome, but a lot of the problems with Down syndrome have to do with cognition and some of your physical abilities and things like that. Well, our son was also blessed with pretty significant gastrointestinal problems. He had anatomy that wasn't quite right and didn't work quite right, and he had a lot of breathing issues. And so, there's a handful of things that are important for life. You have to be able to breathe, and you have to be able to eat, and he really wasn't able to do either one without a lot of help. So we spent the next 2 years every day counting our blessings that we still had him around. And it wasn't until he was about 2 years old that it wasn't a daily occurrence to think, wow, we're so lucky that he's still here. As he hit about 2 years old, his medical issues started to subside, and he still has medical issues, but they're not life-threatening anymore, and we certainly learned how to deal with them through that first couple of years. And there were some really important lessons that I learned through this experience of my son being born and all of his medical complications, because we spent a lot of time in the hospital. And my background in school was as a clinical researcher. So I studied genetics, and I did clinical research in graduate school and as a postdoc. And so I was used to being around hospitals, and I was used to being around patients. But I wasn't really used to being in the hospital and being the patient and being the parent of a patient. So I started seeing my own work from a different perspective. Now, instead of being the person stopping in the room to see if a family might be interested in participating in my research study, now I was the family member sitting in the room with this, young, energetic postdoc or graduate student, or maybe even medical resident popping in, and they're so excited about the work they're doing, and they want you to participate in their study, and it's going to be so great. And I got to thinking to myself, at first I was saying yes all the time. Well, of course I would do that because I was in their shoes before, and I understood how hard it was to get this participation. But then I started thinking, well, you asked me to be in your study, but you didn't even really tell me what it's about, or why anybody cares, or who's it going to help. If I'm going to put myself or my child through, something they don't have to be going through, what's the impact? And so I started really thinking about that and started asking some questions that I should have been asking all along, but wasn't. And it made me realize that I was doing the same thing that those researchers were to me, that I was doing that to other families. And it wasn't like a single moment, change of heart or anything like that, but it really changed my mindset over the course of a year or so, maybe even that full 2-year time. And I found myself thinking that never again, ever, will I do research that's not important to the stakeholders that are most affected by the answer. It just didn't make sense to me anymore to do a project without having talked to patients or having talked to families and really understanding what the problems are and what the barriers are, what the issues are. And then also understanding, once I know the barrier or the problem, what's the real outcome that you're interested in? Because if I answer or solve the problem or the barrier, but with the wrong outcome, it still doesn't help you, right? So it really changed the way I thought about research. And I was a stay-at-home dad at the time when Elijah was born. I resigned from my position as a postdoc. I was on my way to accept a faculty position, and I declined it and just stayed at home with my son for almost 4 years. And when I went back to the workforce, I had a couple different jobs. I taught in the university, which I really liked. But then I landed at this place called Michigan Public Health Institute, where I work now. And they were doing some work with this organization called PCORI. And I didn't know about PCORI at the time, but as soon as I learned, I was hooked. And so just in case any of you aren't familiar with PCORI, I do have a few slides, and I'll go through them here for you, just so you can understand who PCORI is and what they do, where they come from. So I use that word PCORI all the time. It's an acronym, PCORI, and it stands for the Patient-Centered Outcomes Research Institute. And it's just easier to say PCORI once you know what that means. And PCORI is an independent nonprofit organization that was created by the Affordable Care Act. So when Affordable Care Act got signed into law, there is language in there that created this entity, created this nonprofit organization. And it defined some things like what the budget for PCORI is, like their operating budget. It defined the type of research they were going to fund. It defined to some extent the priorities for that research that they were going to fund. And so something that I always have found interesting was how or where PCORI's money comes from. And so as part of the legislation, there was a trust fund established called the PCOR Trust Fund. And for 10 years, from the time that it was authorized in 2010, it had 10 years of guaranteed funding that came out of the U.S. Treasury General Fund, the Medicaid and Medicare Trust Fund, and then a fee that's assessed on private and self-insured health plans. And so if you have private or self-insured health plan in basically any United States insurance company, then you would be contributing a small amount of money each year to PCORI. It doesn't go directly to them. It goes into a fund, so they don't actually directly touch that money that's coming in from the insurance companies. But it's only a couple dollars, I think, per person. I don't actually know what it is today. It used to be a little over $2 back when this first started. And it adds up. It makes for a pretty significant budget. PCORI's budget going forward, I think from 2019 through 2029 ranges anywhere from $275 million on up to almost $400 million a year. So they have a pretty notable research budget for being an independent nonprofit. So let's talk a little bit about what PCORI funds. The main thing that PCORI funds is something called comparative effectiveness research, or you may have heard the acronym CER. And so folks that work around PCORI use that acronym a lot. CER stands for Comparative Effectiveness Research. And the idea with comparative effectiveness research is it compares two or more options. So imagine there's two treatments. You could take Tylenol for your headache, or you could take ibuprofen for your headache. Which one works better and for who? So that is what comparative effectiveness looks at. So you have these couple options, which one looks better? It doesn't have to be treatment. It could be tests, medical tests, diagnostic tests, or algorithms. It could be even broader about the health system, like models of care. Which model of care is better? Team-based care versus individual care, or something like that. So really, really broad spectrum. One thing that was specific about that, though, for PCORI is the two comparators had to be proven effective. So if they weren't proven effective, you couldn't do a study that compared them with anything else. They had to already be proven effective. And so the other things that PCORI fund are really important. They do make up a smaller portion of PCORI's budget, but they also fund methodology research, methodology into how to conduct comparative effectiveness research, and the types of methods that are used, like the statistical methods that are used to analyze the data or design the studies. So they fund studies like that. And then they also fund research support projects. And so ATS, I believe their funding is through an engagement award. And that is one of these types of research support projects. It's about building capacity. It's about building infrastructure. That capacity could be towards, for example, stakeholder engagement. It could be towards dissemination. Could be just for building infrastructure. So lots of ways that could be applied, learning knowledge about your stakeholders, stuff like that. So fairly broad spectrum of things that PCORI funds, but their main bread and butter, if you will, is this comparative effectiveness research. And so this idea of comparative effectiveness isn't really a brand new idea that PCORI came up with. That's something that's been around for a while. But if you've ever been around PCORI, I am certain you've heard the phrase that PCORI is research done differently, or it's changing the face of research, right? So what's different about it? What makes PCORI so different? And there's really three key points that make PCORI different from other research funders. The first one is that the research focuses on topics, questions, and outcomes that are important to patients and those who care for them. And it's that outcomes that are important to patients that really sets PCORI apart. Most research studies are based on outcomes defined by clinicians or researchers. And it doesn't mean that those outcomes aren't important. And so if I sound like I'm suggesting that, I'm not. But what is important to a clinician about a research question or a researcher about a research question may not be the same as what's important to a patient or a family member caring for that patient. And PCORI wants to see that you are taking that into account in your studies. And so maybe you're still measuring that outcome that the clinician is interested in, but you better be also measuring the outcome that the patient or the family member or some other stakeholder, maybe it's a payer, maybe it's public health, whatever, is interested in. So that's the one thing. The second thing is they require that their funded projects work closely with lots of different healthcare stakeholders. Patients, caregivers, scientists, clinicians, health systems, whatever. And I think when people hear this and they don't really know much about PCORI, researchers especially, when we hear this, and I know this was true for me, and I heard this like, well, of course, that's what you do. You can't do research in a vacuum. You collaborate, and you can't do a clinical trial without patients, because who's going to sign up to be in your clinical trial? So I kind of, I hear this and I think, oh, that's not really that different. So you need the next bullet to understand why that's so different. And this is talking about engagement. And so PCORI requires that patients, as well as other stakeholders, be engaged in the research that they fund, not as subjects. So we're not talking about, will you sign up and let me test my Tylenol and ibuprofen on you to see which one is better? It's, will you come be part of my research team and help me develop the research question, or the outcomes, or the methods, or the approach, or help me interpret the results? What does it mean? Or how do I share it with your community? So really about the nuts and bolts work of the research, not necessarily engaged as just a subject in the study. And so that's where it's very different. So even though probably most researchers, especially in clinical science and basic science, would say they do already work with a range of different stakeholders, this is part of the collaborative science process, most don't do it in the way that PCORI is talking about. Sort of this deep engagement, and especially with non-professionals, patients and families of patients, caregivers of patients who are not typically part of the healthcare workforce or the research workforce. So I want to focus in from here for the rest of the talk, and I have about maybe 10 more minutes or so, 10 to maybe 12 more minutes. I want to talk some more about this patient engagement piece. And so I'm going to share with you a few studies that my team has conducted over the last 4 or 5 years that really helped us learn about how to do engagement and what works and what doesn't work in the context of rare disease research. And so I don't know if you read it, but on my disclosure slide, you might have noticed that my office was program office for PCORI's pipeline to proposal funding mechanism back in the, 2013 to 2016. And through that work, we being CSHIP, my team, we learned a lot about patient engagement. And we actually developed with other partners, the other offices that were these pipeline program offices for PCORI, developed a lot of engagement resources in collaboration with PCORI and other professionals around the country, and researchers and clinicians and patients. We developed a lot of these resources, but we had never really used them. And so I kind of felt like it didn't make a whole lot of sense that we were developing all of these things and we couldn't really say for sure how well they worked. And so we started trying to compete for additional funding from PCORI, and we learned, what it means exactly to engage with stakeholders, so I want to share some of that with you for the last bit of my talk. So there's 3 projects on lots and lots of lessons. I won't be able to share them all for sure this afternoon, but there's 3 projects that all kind of relate together. I'll show you all 3 of them just in name, but I'll only talk about 2 of them. And in order to talk about them, I have to tell you about this one project that sort of kicked them all off. It's called the Inborn Errors of Metabolism Collaborative. And you don't need to get too caught up in any of the details, and especially the numbers. You can just ignore the numbers. They don't really mean anything in this story today. I just don't have the ability to take them off my slide. So the Inborn Errors of Metabolism Collaborative is multi-state, intended to be nationwide collaboration of researchers and clinicians that are interested in understanding what we call natural history of metabolic diseases, especially those that are identified by the newborn screening process. And so there's about 52 of these, depending on the state that you live in, that newborn screening programs screen for. And it turns out this natural history thing, I think speaking to a rare disease audience, probably most people know what that means, but if you don't, this is what happens to a person from the time either they're born, if it's a genetic disease, or if it's something that that develops after you're already born. Then from the time it develops until the time that you die, that's the natural history. It's basically just what happens if you don't do anything, if you just watch. And that's really important in medicine, because you have to understand what happens if you do nothing so that you know how to intervene properly, right? What's the right treatment? Where, when, how do you intervene? And so for many of these rare metabolic disorders, and really for rare diseases across all kinds of spectrums, this natural history is just not known. It's hard to study, and it requires, broad collaborations with many institutes, often across many state lines. And that is exactly what we built with this Inborn Errors of Metabolism Collaborative. And after this slide, I'm going to use an acronym for this, and I hope it won't trip people up, but we always call this IBEMC for Inborn Errors of Metabolism Collaborative. So IBEMC. So the IBEMC project, you'll notice, has researchers and clinicians sort of giving some input, and then also families. But I want to highlight for you the fact that researchers and clinicians are sort of on one side of the box, on the top there, and the families are on the bottom side of the box. And while the figure wasn't made intentionally to demonstrate this, it very nicely does. So researchers and clinicians conceive the project, run the project, make decisions about the project. And family members were always important to this group and were always consulted and asked for input, but they didn't have decision-making power, and they weren't necessarily at the table from start to finish. It was more of a, here's our great idea, what do you think type interaction. And so it was a start at patient engagement, but not exactly the patient engagement that PCORI wanted to see. So that's the background project that set up these few projects that I want to tell you about. And they're all under one big umbrella that we call the IBEMC Stakeholder Network projects. And there were 3 of them. So that IBEMC project that I was just telling you about is to understand natural history of these conditions. And then the stakeholder network was intended to make a very fundamental shift from this network being clinician and researcher centered to being patient centered. And it was a lot of work and a lot of time, but I think we were able to truly accomplish that. And so there, you see there's 3 projects there. There's a PKU project, and a Quest project. Those are both completed, and I'm only going to tell you about the PKU one. Maybe some other time, if we have more time, I can talk to you about the Quest one, and then I'll talk to you about the Rare project. And some of you in the audience, I know at least Andrea and Jade, are participating in this project. It's almost done, but not quite. So I'll share just a little bit about that one too. So this IBMC Stakeholder Network was founded on just a couple really simple but important principles. We recognize that patients and their families have experience and expertise, which is really, really important. Expertise that's critical for identifying the most important research questions and identifying how to answer them based on their own personal specific needs. Right? It's exactly what we need to know as a researcher in order to ask the right question and develop the right solution. And I got quoted as saying a statement once, and I actually took some flack for it, but I don't care. I'm going to say it again, and if I take flack for it again, that's okay. And that is at the bottom of the screen there. We should not ever be guessing what patients need. We should just be asking, right? Patients are very happy to join a conversation if you're willing to genuinely listen and genuinely do something about whatever it is they might be telling you. And so there's no need for scientists, researchers, even clinicians doing any type of research project to have to guess at what the patients need. We can ask, and that's okay. And I will say that obviously there's a lot more than just picking up the phone and saying, hey, can you just tell me what you need? But nonetheless, if you take the time to do that, you can have an answer to that. So first lesson from this work is right here on this slide. If you take a look at our leadership team, all of our stakeholder engagement projects look like this, and honestly, all of our projects in general look something like this. So the project leadership, the PI of this particular project is my former director, Cindy Cameron, and she's a public health professional. The woman next to her is Sue Berry, and she is a geneticist, a MD geneticist. And then, of course, you see me there in the top corner. I'm a researcher by trade. And then you see also our lead patient partner, Jane Pilditch. And Jane is, she's a parent of a child with a metabolic disorder, but she's also a very skilled project manager and project coordinator, and she actually happens to be the associate director of my center, the Center for Strategic Health Partnerships. And so when we dove into this project, we found that because we had all of these perspectives as part of the core leadership, we made decisions right on the front end that considered all of those perspectives. And I think if me or Sue or Cindy were not part of the conversation, then we wouldn't have changed. Like it didn't necessarily change where we were headed. Any one of the three of us might have come up with exactly the same thing. But having Jane as part of the leadership and having decision-making power and having equal power with the rest of us to say, no, we should do it this way, or we should do it that way, or we're not thinking about this right. Families aren't going to like this, or families aren't going to do this. It's not fair to them. Without that perspective, I'm not certain this project would have been successful. And it was very successful. So lesson number one, your leadership team ought to look a lot like the rest of your team and who you're trying to serve. So we had funding from PCORI for this project. It was a 2-year project. We were trying to understand the important research questions and the important outcomes for a group of individuals affected by one specific disease. It's called phenylketonuria. The condition is not so important, but they all have the same or stakeholders around the same condition. We had national advocates, we had patients, we had parents of patients, clinicians, public health, researchers, all at the table for 2 years, meeting with us, talking with us. And the really neat thing about this project is ultimately we landed on what we thought was a very fundable research question. It fit PCORI's funding model, and we decided we were going to write this research proposal. And truth be told, we actually landed on about 10 or 11 ideas like this, but only a couple of them really fit with PCORI. And the one that we pushed forward was one that fit really well with PCORI and had a lot of support from not only our families and our patients, but also our clinicians and our public health folks and really all of our stakeholders. And so this is the study, and I don't want to go into the details of it because the details are not so important. But it was a very comprehensive study looking at 2 different treatments for this phenylketonuria or PKU, and it was a non-randomized clinical trial. It was comparative effectiveness research, exactly the type of research that PCORI is looking for. And it turns out we could not get this study funded. So, we did a lot of work on the front end. It took a lot of time to build relationships and have discussions and finally get to this spot. and we came up with something that wasn't fundable. And the reason that I share that with you is because, again, we learned some really good lessons here that are relevant to rare disease. So when we started looking at the comments we got from reviewers, the reason that the work wasn't fundable was mostly, not entirely, but it was mostly things that we couldn't really change and we didn't have any control over. So probably one of the biggest criticisms of our study was that we had insufficient evidence that there was a need for that study to happen. So they were looking for specific evidence in the literature, maybe a systematic review saying that, doing this comparison of the treatments for PKU was something that was really needed in the field and it was going to help patients. Well, for those of you who are rare disease researchers, you know that systematic reviews are not so common for rare diseases. There's not usually enough literature for any one single rare disease to have a systematic review or even to warrant one. So, the promise of having more evidence really isn't that great. Same is true with the next thing. There wasn't enough evidence of efficacy of the treatments. So you'll remember in the beginning, I told you one of PCORI's sort of rules, if you will, is that your comparators have to already have been proven effective. And by proven effective, that means you should be able to go in the literature and see, treatment A works, and treatment B works. So it's already been demonstrated. There's good clinical studies, and they have sufficient statistical power and all of those things. Well, again, that's something that doesn't often exist in the rare disease literature. Many rare diseases are treated in a way that we say it's empirical. So the experience and knowledge of the individual clinician that might be taking care of patients with a certain rare disease learns how to do it kind of on their own, sometimes even by trial and error, because there isn't sufficient literature to guide that. And they figure out what works and they manage their patients that way. And that doesn't work as evidence for PCORI, at least not as strong evidence. And then, of course, I'll skip the no buy-in from payers. That's something we could have fixed. We just didn't know better at the time. But then the last one, insufficient sample size. Well, of course, right? It's a rare disease. So how do you get enough people, not only on your research team, but then when you get to doing the study to actually participate so that your statistics work and so that you can make conclusions? And so, many of these things were points that we didn't really feel like we'd ever be able to address in this study. And so, we started thinking about this a little bit differently. I had the opportunity to meet up with some PCORI ambassadors, and PCORI ambassadors are, they don't work for PCORI, they don't speak on behalf of PCORI, but they're individuals who know PCORI well. They understand the work that they fund, maybe they've been funded themselves or been part of projects, and they believe in PCORI's mission. So there's sort of some passion tied to these folks. And there's a group of PCORI ambassadors that are specifically, has some interest in rare disease. And so I started meeting with some of these guys, and there was I think 6 or 8 of us that started having conversations. And we had conversations for a long time, probably, I don't know, a year. Actually, for a whole solid year, we were meeting about once a month and talking about, how can we as a group of ambassadors do something to make it easier to get a rare disease research study funded? Can we make recommendations to PCORI? Can we come up with new methods, new models, new approaches? What is it that we can do? So we met and we talked for a whole year. The first time we met was at a PCORI annual meeting. So we were still talking the next year at the next PCORI annual meeting, and there was an announcement of some new funding that was coming out. And I started texting all the folks that I have been talking to about, what we can do. And I said, all right, I have it. Let's write a project. Let's write a grant, get some funding, and we'll take a look at, how we can overcome some of these barriers that I faced in the study on PKU and many other rare disease researchers face when they're trying to get funding for their particular disorders of interest. And so here's the model. With any one given rare disease, you're going to have limited sample size, you're going to have limited understanding of natural history, probably limited evidence-based guidelines. And so because of these three, typically the ability of you to generalize your results out to other populations or other groups is pretty limited. You usually can't do that because you have such a small sample yourself. And typically speaking, with a research project like this, there's one single condition, or sometimes it's maybe one group of conditions that are all similar. And then the study focuses on many aspects of that one particular condition or one particular group of conditions. So I said, what if we think about this in a more cross-cutting way? There's got to be things, questions, barriers, problems, symptoms that are experienced broadly across many, if not even all, different rare disease communities. And so, with one rare disease community, say this first blue triangle or purple, whatever color that is, you have a limited sample size and limited. But then you pull in another community and another community and another community, another. And so the more communities you pull in, the more stakeholders you are starting to affect, right? And this group gets bigger and bigger and bigger. And so what if there was a question or a set of questions that was relevant to 100 rare diseases or 1,000 or 7,000 or maybe even all? I don't know what the number is for all, at least 7,000, right? So, what if we could find that cross-cutting type of question, one single aspect, but true across many rare diseases, and build a research project around that? And so that's what we tried to do. And there's some challenges in that. So first of all, we needed a model to test it out. How are we going to know if this is going to work? What's our cross-cutting idea? And so speaking with all of those PCORI ambassadors, there was actually a common theme that emerged very, very easily. And that was mental health concerns. So within every rare disease community that I've ever spent time with, concerns with mental health are a real and true barrier that people face, whether it's things like depression and anxiety that are related to things like diagnostic odyssey or loss of job or stress on family, or maybe the particular rare disease causes some of those mental health conditions like anxiety and depression and other things. There's so many different ways that mental health intersects with rare disease. We said, well, maybe this is our thing. So we went into the literature to look and see if anybody's ever done this. And it turns out they haven't, or at least we couldn't find any papers. So there's lots of papers in the literature about mental health and rare disease, but no papers that sort of look at this in a cross-cutting fashion, one particular mental health concern across any rare disease, all in the same study. It just doesn't seem to exist. And so this was the starting point for our rare disease and research engagement study, or we call it RARE. And so there's three key objectives here in RARE. One was to build a national network of diverse rare disease stakeholders that are interested in advancing PCOR, patient-centered outcomes research, and we've done that. We did a lot of work on the front end. We had a big convening meeting. About 40 or so stakeholders were there, and that's the meeting that I mentioned earlier that Jade and Andrea participated in with us. And at the end of that meeting, that was supposed to be a kind of a one and done thing. We did a bunch of work getting ready, and then we met with the stakeholders to get feedback and direction. And then really the rest of the interaction was supposed to be our initial core team of rare disease stakeholders and reaching out maybe to these other stakeholders as needed. And that didn't quite go that way. After our convening meeting, I think now we've met another 2 or 3 times with the big group. Not everybody can come, but it's about 40 people, and most people show up because they're interested, and this is a new idea for them, and people see value. It's like, not only can I learn something about the rare disease that I'm interested in, but I could be helping lots of people with lots of different rare diseases learn something that they need to. So we have a lot of buy-in for this idea. So the other thing was we wanted to identify some examples of cross-cutting patient-centered outcomes and research questions that were amenable to comparative effectiveness research studies. And we did do some work on that in our convening meeting, and we're still analyzing that data. I don't know if we have accomplished that yet or not. We definitely have some good ideas, but I don't know if we've really identified strong possible studies yet. So that's still emerging. And then the last thing, and I'm going to share just a little bit of this with you. I notice I'm running longer in time than I was planning. The last thing is developing a comprehensive engagement model, something we've been referring to just as a roadmap to enhance collaborations between rare disease communities, and then to be able to implement and sustain very robust stakeholder engagement across rare disease communities, with the intention that if rare disease communities already have that engagement, when research teams get funding, they decide they want to work in a certain area, they have a group of stakeholders that already know how to do engagement, and they can help, right? They can come alongside and say, well, look, this is what you need to do. If you want to work with us, here's what you have to tell us. Here's what you have to do. Here's how it works. Let's start a partnership. Let's make this happen. So that's what we were trying to do. And like I mentioned earlier, this project isn't done. But it's wrapping up. And so I'm really excited about this stakeholder engagement model. I had to cut some of it off because I don't have permission to share it just yet. Because our project is still ongoing, we need to share these things with our program officer and with some of our other stakeholders before we share them broadly. But there's at least a little bit of the model that I certainly can share with you. And then when the rest is done, I promise you we'll share it out. But we really landed on 2 big phases for our stakeholder engagement model in rare disease. One is a pre-engagement phase, and then the other is something we're thinking about as being active engagement. And pre-engagement is really important in the rare disease community. Planning for engagement, knowing that your stakeholders might be few and far between, and might be really taxed with doctor's appointments and stress and mental health concerns and all kinds of things, financial concerns, family concerns, all of these things. There's a lot of planning that needs to go into your engagement. And so we highlight a lot of those things and give some practical approaches and practical steps that research teams can use to try to do some of that planning. And then the initiation for engagement is an interesting one for me. We're actually trying to do some more work in this area with some different projects. And this really gets down to concepts of equity and social justice and thinking about trust and thinking about when you approach a community, what do they hear and what do they see, and have you done anything at all to earn their trust and to understand their culture and to understand their community, and before you just kind of knock on the door and say, hey, do you want to come be on my research team? I need you for something, right? So really we dig into that idea and that part, and then building relationships, I think is maybe the least new type of thoughts and information we have. Building relationships is important in any engagement, and rare disease engagement is no exception to that rule. And then in the engagement circle, we get into things like mentoring other organizations so that they can take some of this work on their own and go keep making it happen and keep moving on. Sustaining the engagement, finding funding, developing governance, and then making sure it stays current, making sure you're actually using it. Taking the engagement relationships that you built and using them to leverage other resources to do research projects, right? So engagement's one thing, but research is another thing altogether. And so how do you take that engagement you built and apply it to a research project? And then another thing that I think is going to be really useful for folks is, how do you end engagement? What does the sunset look like? How do you do that in a way that's not damaging to your partners, not damaging to your relationships? So anyways, that stuff is going to be in the model. I didn't mention this early on, but my center, CSHIP, just recently launched a social media platform. So we have an account on Twitter and on Facebook and on LinkedIn. And we post on all of them, and a lot of the content we work on together and just kind of make periodic posts. But on Twitter, I also do some ad hoc posting on there. And so if you follow my center, it's at, instead of the pound sign there, that's our hashtag, but at, and then that exact hashtag of CSHIP at work, CSHPATWORK. You can find us on Twitter. And as things like this, the model and some of the other resources that we have, our videos and all of that, as they emerge and as they're ready, that's one of the places that I will be disseminating them. And so if you follow us, you certainly would see them come through as they're finished. And we want people to use them. They'll be shared in a format that you can edit, make your own, and use to support your own research engagement, your own projects. So encourage you to follow us on social media, especially if you're interested in getting a hold of some of these resources as they emerge. And if you don't remember CSHIP at work to find us, you also can follow me on social media. I'm on Twitter. And I'm certain I will be sharing any of these things that I, on my personal Twitter, that I share on CSHIP, and mine is just at MJEdic is my handle on Twitter. So do feel free to follow me. So with that, I apologize for going longer than I was planning. I just want to take maybe one more minute at the most to just recognize my team. So this is me, of course, and Jane that I mentioned, my associate director. Katie is our research associate. We're in the process of hiring this person right now, but haven't sealed a deal yet. So if you're a scientist, you're looking for a job and you're interested in this work, maybe reach out to me. Can't promise that job will still be open, but it might be. And then we have a handful of coordinators. Two of our coordinators are senior coordinators. They've been doing this for a long time. And we have one new coordinator that's been with us for about a year. And they do all of the high-level administration work for the projects. They lead all of the partnership building efforts and the conversations, and they're facilitators and things like that. And then probably our two most important staff members on the bottom there, Drusilla and Nanette. They're our support staff. So Nanette is our finance person, pays all the bills and keeps all the things running for us. And Drusilla is our program assistant, and she's amazing. So amazing that I'm going to have to lose her as a program assistant. I'll probably be promoting her pretty soon. She's not been with us very long, less than a year, and she's just a shining star. Without her, all of us would probably crumble. None of this work would happen. So anyways, that's my staff. Lots of collaborators. I won't go through them. I'll just leave that up there for a second. And then I'll leave you on one final note. And that is, I recognize when I told you my story and introduced you to my son, I never told you what happened to him. And he was a really sick little boy to start with, but he's 14 now, and he's doing just fine. So I'll leave you with this picture of my son at various ages. This one in the bottom corner is probably just from a month ago. This is my daughter's high school graduation. So he's 14 in that picture, but he's a variety of ages, and you can see he's a young, happy boy, and he's doing just fine. All of his time in the hospital, obviously he survived and is no worse for wear. So I just want to make sure I share that out so you are left wondering what happened to my little man there. So thank you everybody for listening. Again, I apologize for going longer than I was planning. Sometimes it's hard with no audience to stop talking because there's no social cue. So really do apologize, but thank you all. And if there are questions for me, Andrea and Jade both know how to get in touch with me. They can certainly shoot me email or call me or shoot me a text message. And any of you that are listening, do feel free to message me on social media. You can find me on Twitter. You can find me on LinkedIn. You can find me on Facebook, but don't message me there. I don't check Facebook very often, but probably about once a year. So probably not the best way, but do feel free to reach out if there's questions or anything you want to know more about. And thank you for your time. Thank you for listening. And I hope you guys are having a wonderful conference. All right. Thank you.
Stay tuned, we have a lot more information coming your way.
Thank you for joining us today with the Twist of Fate Bridging the Gap Medical Symposium.
And make sure to check out our website down below and maybe our YouTube channel.